PhD manager. 1 minute. Push.
Good morning, everybody. I am from an entirely different specialty. So anyway, thank especially my colleague Dr. Santosh K. Raghavan and organizing secretary Mr. Salvan and other administrators for inviting me. So when he called initially, I got confused what I will present here because I never presented anywhere other than the orthopedic specialty. So he told you mix some rehab along with that. So anyway, I have included so many rehab, but later I realized another person is presenting post-op surgical rehabilitation. Anyway, I started as a knee arthroscopy and arthroplasty, but now into most of the time in shoulder scopy and plasty. So I will be talking about more on this today. And once again, thank you. So, just an anatomy, anyway, we all gone through it. So just to brush up multi-axial ball and socket, most flexible joint. That is the difficulty we are also facing. Less mechanical stability when compared to hip joint because hip also is a ball and socket joint. And stability is entirely by soft tissue. It is not by a bony stability, is not there actually in the shoulder. So, stability compromised by mobility. This is a simple anatomy. It is outermost muscle is deltoid. Then you have the rotator cuff muscles. I'm just going fast. And the biceps long head also playing some role in the shoulder. And there is some ligaments contributing it. And another major thing is the glenoid labrum. So see the mobility of the joint. You can say it's like a 360 degree of rotation, and all these things you cannot imagine how the shoulder will remain in that position. So the whoever designed our shoulder, I don't think we can design something like that. So for what patient coming to you? Trauma to shoulder, direct or indirect, pain of insidious onset like adhesive capsulitis, rotator cuff tear or progressive stiffness of the shoulder. So causes just glenohumeral and acromioclavicular arthritis, ligamentous and labral lesions, glenohumeral and acromioclavicular joint instability, osseous fracture, osteonecrosis, neoplasm, infection. And there are periarticular causes like impingement syndrome, biceps tendinitis, rotator cuff, and long biceps tendon tear, subacromial bursitis, and adhesive capsulitis. So most of the conditions, especially trauma, we can improve by our basic thing is rest, ice compression, and elevation. Then comes the physiotherapy role. Sometimes we support with local steroid, PRP, which is just evolving, still a controversial thing, and arthroscopy or open surgeries. So arthroscopy now it's getting in our field. Arthroscopy is one. We are include more and more indications are coming into the arthroscopy like Bengard's lesion. Now I cannot imagine a repair, open repair of Bengard's repair is more traumatic than the dislocation. So arthroscopic repair made it so simple, and biceps tenodesis or tenotomy, Hill-Sachs lesion, we can manage arthroscopically by doing remplissage. Rotator cuff repair, now almost like 80% of cases is done by arthroscopically. Superior capsular reconstruction, Letarge procedure, and subacromial impingement, we do acromioplasty and decompression, and AC joint dislocation or arthritis. Arthritis we manage by lateral and clavicle excision by Mumford procedure. So dislocation of shoulder, commonly anterior dislocation, what all things we face? One is Bangard's lesion, as you already know. Commonly, because of the anterior, I am going to anterior in most of the cases. Hill-Sachs lesion is a posterior superior part, there is a bony defect. And again, in the recurrent dislocation of shoulder, we are doing Latarjet procedure or anatomical reconstruction. Now the Latarjet procedure also now started doing arthroscopically. It is slowly going out of, it is not going to be an open procedure very soon. So this is glenoid, and this is the glenoid labrum. So you see I put the probe inside to show the, so this is after we make a bump of the labrum over the glenoid margin. And this is a Hill-Sachs lesion on the posterior superior aspect of the shoulder. So depending on the size and the depth of the remplissage, or we can measure is an off-track lesion or on-track lesion, or even dynamically, when we do arthroscopically, we will see whether this is coming and impinging on the anterior part of the shoulder. Then we will go for a remplissage procedure. This is that we put two anchors and suture the capsule to the defect. So it will prevent the forward pushing of the, it will prevent the forward pushing of the head of the humerus. So just going fast rehab, these are the things passive and active, assisted active ROM in the first 3 weeks. And 3 to 6 weeks we started on assisted plus active ROM, and 6 to 12 weeks our aim is to get full range of motion and starting of strengthening. Then comes a Latarjet procedure. Sorry, I don't have the video. Latarjet procedure is as you know, we take the acromion with the short head of biceps and putting in the lower third of the, by splitting the subscapularis, we put the short head of biceps along with the acromion fixed to the glenoid. And we repair the labrum also along with that. This is the final, the last one, D. This is how it looks. But now, again, Latarjet also is not 100% this thing. So there is another. Now we have failed the Latarjet also. So now even Latarjet is a little more aggressive procedure. So now something called DAS procedure is called dynamic anterior shoulder stabilization. Instead of cutting the bone, this is a little more easier than the Latarjet procedure, and you can do in arthroscopically. You take the long head of biceps. Before I was telling acromion plus short head of biceps. This is just taking long head of biceps and fixing at the same place where we do the Latarjet. So this will act as a sling to prevent the forward movement of the shoulder, preventing dislocation. But we need to be very careful in selecting the patient, because glenoid bone loss should be less than 15 to 20%. Otherwise, this is going to fail. In bigger, like 20-25% of bone loss is there, we'll usually go for Latarjet or an anatomical reconstruction using the iliac crest graft. So Latarjet, you should understand that when you do the Latarjet, it's a bony healing. We need to wait for that. So it will take around 6 to 9 weeks. So before that, we should avoid mainly the external rotation of the shoulder. So use a night sling. Use at night while sleeping also, and remove the sling at 6 weeks. Precautions may vary per surgeon, but I usually avoid external rotation for up to 5 weeks. I told you bone healing. No shoulder active range of motion in any plane until 5 weeks. Intervention is assisted ROM of elbow and shoulder girdle. PROM, passive ROM should be neutral and careful about external rotation limit. So 6 to 12 weeks, our aim is to get full movement, but even then we will be very careful about the external rotation. So I'm not going to detail as I told you. Then comes the shoulder impingement. We will go for a subacromial decompression, sometimes acromioplasty, And if associated with AC joint arthritis, we end up with Mumford procedure, lateral and clavicle excision. So then comes the rotator cuff. This is always some problem with the physiatrist or physiotherapist we have, because this rehabilitation is a difficult time. It will take around 6 months to 1 year for the rehabilitation of the rotator cuff repair. So don't be in a hurry, because it is going to fail if you are in a hurry. So this is the glenoid, that is the torn rotator cuff on the top. And this is, we take some bites on that, and I have a full video, but it is take around 10 minutes itself, so I'm not showing a some. This is the single row repair. We just put the anchor and we fix to the humeral head. So factors influencing repair. See, it's a single row, and there are techniques, single row or double row. Double row will more stability, but final result showing not much difference whether it's a single row or double row. And extent of the tear. That is a very important thing. So if it is supraspinatus only, we can start mobilization maybe at 3 weeks. If more than supraspinatus, infraspinatus or subscapularis, we need to wait for 6 weeks to start mobilization. There is no problem in mobilizing the shoulder. We will get a full movement even if we wait to 3 to 6 weeks. We never faced any difficulty. So don't be in a hurry in rotator cuff, because it is going to improve, because you corrected the pathology. We very rarely we face fixation. If you mobilize early, we are going to fail the. And sometimes, if not possible to repair, we do augmentation or superior capsular repair with a autograft, or sometimes with the fasciolata we take and augment the support the superior capsular reconstruction. This is showing, this is one of the double row repair. You see, it's very nicely, the edges are well, but it's good fixation, but it'll take longer time, more implants, and more expense for the patient. So implants are, each implant costing from 15 to 20,000. Each anchor costs 15 to 20,000 rupees. So you need 2 anchor means just jumping 40,000. So we need to discuss with the patient, then only we'll go for it. So just rushing through goals in the first 3 weeks, actually no active role from your side. It's mainly mobilization, elbow mobilization, and elbow and hand mobilization. But you should be careful if you are done biceps tenodesis, we cannot mobilize. Active mobilization of elbow is not allowed. So mainly pain relief, swelling, so we need icing, and all these are the initial first 3 weeks. So I'm not going into detail of this thing. As I told you, some surgeons use abduction pillows 30 to 45 degrees after repair, because it may be some stress at the means muscle is retracted, so we need to pull it. In that case, we give some abduction pillow to keep it 30 to 45 degrees. That will continue up to 6 weeks. But after 3 weeks, invariably, we'll start on some movements, most probably passive movements up to 6 weeks. So these are the simple exercises. You can say it is more of a passive or little bit assisted movements. So when I am starting my post-graduation, I have seen some, I don't know, now I have not seen in physiotherapy center, big ring wheel, shoulder wheel they call. Now it's all, I think, not necessary. That is a big trauma to the patient, I think, sometimes. I don't know what is your experience. I feel it is, it's not necessary. So many things are, so many changes are happened. I'll show you how simply we can do with, so now 4 to 6 weeks. We need to, abduction will be limited, assisted active range of movement will be started. Not active range of movement should be started at 4 to 6 weeks. Active movements will start at 6 weeks only. So these are some external rotation tips. You can easily train. And because first 6 weeks we will not allow them to do active. So to make that active part to get over, better to do lie down and do it. This will help. So 7 to 12 weeks, we actively start on physiotherapy. One is we start on a range of movement exercises, assisted passive and assisted active range of movements, and some strengthening exercise. But one of the important thing is we need to always, we always concentrated on the shoulder. But we always neglect shoulder girdle. There are other muscles supporting the scapula. Sometimes we call core muscle, or this rhomboids, trapezius, serratus anterior. We need to concentrate on all these things in from third week onwards. First 3 weeks, even we will not allow to touch all these muscles. And the previous speaker has told me, there is one thing that she has told, that keep pillow while lying down. That is neglected always. We need to tell each and every, when I go for the rounds, the pillow is removed. And the patient, the hand will be lying like this. That is stretching the capsule, and even if you have repaired the subscapularis, and even the part of the supraspinatus, it is stretched. So always keep a pillow, and we need to inform the patient to do that, because all our patients is not that old, so they will understand the thing. So up to 12 weeks, no lifting of weights, no sudden jerk movement, no supporting of body weight by hands and arms while getting up from the chair or the bed, no excessive back behind the back movements. So I am not going through I told you I mix up with the little bit rehab. I think that next speaker may be supporting it. So I don't want to discuss much. So our aim at 12 weeks is full pain-free, passive range of movement and active range of movement. Minimal to no substitution pattern with shoulder active range of movement. Perform all exercises demonstrating systemic scapular mechanics. See, that's what I told you. The shoulder girdle, we need to concentrate on it. Otherwise, you are not going to get the shoulder movements, glenohumeral movements, without stabilizing the scapula. So rehabilitation never stops at 12 weeks for a massive rotator cuff. It goes on continuing. Now we will start on real strengthening of the rotator cuff muscle. That is after 12 weeks. So our aim is full range of movement, active range of movements, and gradual return of functional activities. But precautions: no heavy lifting of objects more than 2 to 3 kilos. No sudden lifting or pushing activities, no sudden jerking motions, no heavy lifting, and no sudden lifting and pushing activities. Okay, and early return to sport by 4 to 6 months. But if you are volleyball player, we'll always say like overhead activities like volleyball or basketball, they need to come back to sports at 6 months only. So now coming to shoulder arthroplasty, osteoarthritis of the joint, and fracture of the head of the humerus, severe rotator cuff tendon arthropathy. Now, type of arthroplasty, hemi-anatomical reverse shoulder arthroplasty. So this is a 48, you know, from your X-ray itself we can show this is a surgical neck of, anatomical neck of humerus. And you see the CT images, one of the case done by me. So we have done ME. This is a 34-year-old female. So we have done just 1 or 2 minutes, not more than that. So this is done hemiarthroplasty, and she is doing well. So shoulder arthroplasty, we will usually start at 3 weeks. But in fracture case, we may require sometimes muscle repair, like maybe supraspinatus, supraspinal subscapular is all like a four-part fracture. So we need to fix it to the when you do the arthroplasty. So then we need to delay maybe up to 6 weeks. Otherwise, if it is a non-traumatic surgery, we will not disturb the rotator cuff much, so we can start early mobilization. So anatomical shoulder arthroplasty, now the indication for anatomical shoulder getting shrinked when all other things are getting expanded, so arthroscopy, because of another thing has come. So this is in young patient we'll do anatomical, and glenoid bone stock should be good and a healthy rotator cuff. This is very important. If the rotator cuff is not healthy, no point in doing anatomical shoulder, which is not going to, it is not going to function. So then comes this wonderful thing, it's a reverse shoulder arthroplasty. Its indication is getting wider. So just see cuff arthropathy, if there but not functional, or pseudoparalysis, acute fractures, like 3 or 4 fractures, when all other options are exhausted, but in rheumatoid arthritis, so low functional demand, physiological age more than 70, sufficient glenoid bone stock, and working deltoid muscle. We don't want rotator cuff. We want mainly the deltoid muscle. But subscapularis is very helpful, but most of the cases subscapularis will be intact. So contraindication is mainly the deltoid deficiency. Actually, otherwise reverse shoulder is not going to work, and severe osteoporosis and active infection. So this is, you can identify what is this? This is actually a hip prosthesis. I got from the net. I don't know. Somebody has put, we cannot, this is a hemiarthroplasty for the hip. They put it on the shoulder. Maybe this is shoulder implant may not be there. Maybe so for some time he will get some pain relief. So see this, how bad the fracture is. And unfortunately, I did hemiarthroplasty. It was fine, very good. But on second day, she got admitted into the ICU with a severe upper GI bleed because of my NSAIDs and stress maybe. She was in ICU for almost 2 weeks because of upper GI bleed. So she come with severe pain and stiffness. So after 6 months, I did a reverse shoulder arthroplasty.
Dr. Paul, yeah. Please sum up.
Yeah, almost finished. This is another case. Somebody has done, fixed the head of the humerus and developed AVN. And we have done the, as you see, even the screw penetrating the glenoid. And we have done reverse shoulder arthroplasty, another happy person. So rehab, actually, like any other plasty, 1 to 3 weeks, we can start, unless if muscle repair is there, then we, especially in trauma cases, we need to delay it for 3 weeks. Otherwise, we can start on mobilizing the shoulder. So take home message. Always remember the healing time of the tissue. Soft tissue healing, 3 to 6 weeks. Bone to tendon healing, 6 to 12 weeks. That is where rotator cuff comes. Bone to bone healing, 6 to 9 weeks. That is where the letargy plays. And first 3 weeks, main aim to reduce pain and inflammation to avoid arthrophyrosis. Always refer to surgeon note discussion and before starting any active physiotherapy. So thank you.
Thank you, Dr. Paul Antony, for giving an insight into